Welcome to the online teaching program for postgraduates in pathology 2. Today's topic is on Anil Handu, Dr. Sumit Gujral sir, Chatterjee from TMH Mumbai. And from next week onwards, we are starting the next lecture of next series on liver. We have 3 classes and 2 slide seminars. The next.
Thank you, Priya. For that introduction, and thanks for sharing younger pictures of me and Anil. So I was very happy to see Anil's picture there. So can you see my slides and now the presentation mode?
Yeah. Yes, sir. Yes, sir. It's in full screen now.
Yeah, fine. Okay, so thank you, Dr. Sumit and Dr. Anita, for giving me this opportunity to share this knowledge on newer parameters in cell counters. We all know that when you have a 3-part cell counter, this is a printout that we get. But other cell counters display on their screen not only histograms but also the scatter plot. So these are the scatter plots, and I mean this is a display on all the cell counters. High-end cell counters like from Beckman Coulter, from Horiba, YH, Sysmex XN, BC from Mindray, Alinity from Abbott, and Advia from Siemens. So why do cell counters do better? We should understand that they really do better because they sample and analyze cells 80 to 100 times than any morphology checking process and arranges a proper output. Can it become more specific to a disease or a disease process? Probably the new parameters that are coming, they are being developed or being derived from revisiting existing data. Some new parameters are coming up. Will probably help early diagnosis very, very early, as it is a screening test, probably indicate outcome and direct prognostic progress. And it can actually become a life-saving tool early in the disease process. Now, if you look at the major 5-part platforms, I'll just show you the processing brief. You must realize that when they do a 5-part, they have to make sure that the red cells do not interfere with the white cell count as well as their differentiation. So everything depends on the concept of lyse. How do you lyse the red cells to get the white cells? At the same time, spare the white cells from the lyse. Now, some of them have a process where they can still bring the cells in the near native state, the white cells in the near native state. Some, of course, may lose cytoplasm to allow dyes and the state start shrinking. So obviously, it is not near native, but obviously that they compensated by getting the dyes to analyze the cell. And you must realize all this analysis in a very short time. We're talking about 20 to 15 to 20 seconds. So the impact varies with the degree of lysis. Then, of course, after that, the signal destination rather than the light source. Light source is, everything is laser. But the signal destination is very important because the signal destination will see whether it analyzes the cell to discriminate based on physical attributes like size, or granules, or nucleocytoplasmic ratio. So therefore, if you look at size, the only cell counters which you can depend on size as a discriminator will be DXH from Beckman Coulter, Alinity from Abbott, Umicent from Horiba, and somehow Advia from Siemens. If you want to base on fluorescence, the intensity of the staining of the nucleus, because we know that the immature cells will fluoresce more than because these fluorescent dyes are predominantly RNA dyes. That you have to depend on XN from Sysmex, BC from Mindray, and Alinity also from Abbott. If it is to be doing about staining and loss of light, because of the staining, the light will either get absorbed, it will get refracted, and based on that, it will differentiate cells because the amount of light that is lost. It is either Advia from Siemens or Umicent from Horiba. Then, of course, the nucleocytoplasmic content, that is how much of the cell is cytoplasm and how much is it nucleus. And that is only possible on the conductivity platform of DXH from Beckman. But as far as granularity is concerned, that is scatter, all cell counters, directly or indirectly, identify granularity. So now if you look at DXH here, you have the scatter plot which shows you a blue population, which is lymphocytes, because they are small in size. If you look, the size is on the y-axis and granularity is on the x-axis. is small in size and less in scatter. Compared to an equally populated cell, which is the pink population, which has got more scatter than the lymphocyte, and also double the size of the lymphocyte. They are the neutrophil. Then you have the orange population, which is the same size as far as the y-axis is concerned as neutrophil, but has more scatter than the neutrophil. They are the eosinophils. Then you have the green population, which are cells which are largest, but they don't have as much scatter as neutrophil, but almost as similar as a lymphocyte. They are the monocytes. Because the nucleocytoplasmic ratio will help identify the basophil population, which is right behind the lymphocyte. Now, if you look at the XN and the BC, along the y-axis is the fluorescence, and along the x-axis is the scatter. So you can realize that scatter is a very important part of this whole thing. Now, if you look at it, the neutrophils, if you look at the nucleus, they have got a lot of heterochromatin, dark staining part. When you look under the microscope, they will not take up the dye. Only the non-dark staining part will take up the dye. And that's why the neutrophils will not have that much fluorescence along the y-axis. So the blue population in the first box are the neutrophils. Then, the nucleus of the eosinophil is, bilobed and more dark than the neutrophil. That means they will not take as much fluorescence as the neutrophil. And therefore, you can see that their fluorescence levels are lower than neutrophils, but almost same as the lowest staining part of the neutrophil. But the scatter-wise, they're different. So the red population shifts further. If you look at the lymphocyte population, which is the pink population, you can see, we know that some lymphocytes are small. They are having more heterochromatin than euchromatin. So you can see that the euchromatin being slower. As the lymphocytes become bigger and bigger, you know that they will take up more fluorescent dye because they've got more RNA. So you can see that it starts closer to the fluorescence, starts closer to the eosinophil level of fluorescence, but it keeps on increasing. But because it is not having much scatter, it is separated from the blue population of lymphocyte. I mean the neutrophils. Then you have the green population, and green population, you know that monocytes have got a lot of euchromatin, and they take more of the fluorescent dye, and therefore they subject themselves to more staining and less scatter. Now, if you look at the next box, which is only blue in color, there are 3 populations you can see. That's called the WNR channel. This is a channel which identifies basophils and NRBCs. Now, basophils are resistant to lysis when the pH of the solution is acidic. That's because the most acidic substance in our body, not hydrochloric acid, but heparin. Heparin has a pH of 1. Heparin is there in the basophil, and that's why it takes up the blue dye. So the basophils will survive the lysis, and along the y-axis, which is size of the cell, because they survive, they become big. They appear big compared to the other cells which have lysed and got deteriorated. Now, we know that the NRBCs are having hardly any euchromatin. So they will be predominantly, hard heterochromatin. They will be behind the white cell population, and they'll come as a red population. So this happens in both the cell counters. Then you have the staining and loss. So Advia by Siemens does the peroxidase staining. So you can see the lower box, which is the pink population there. That's all neutrophils because it's all peroxidase staining. So along the y-axis, you have light loss, and along the x-axis, you have the absorbance. So you can see the maximum absorbance is for neutrophil. The eosinophils have got far more absorbance than neutrophils because their staining is darker, but they'll be slightly below the pink population because it's a precipitant dye. There'll be hardly any light passing through the eosinophil. Now, coming to the topmost slide, you can see that along the y-axis, you have light loss, and along the x-axis, you have got size.
Excuse me, sir. Sorry for interrupting. Sir,
Yeah.
Some of the students have asked, can you use laser pointer?
Okay, fine. Okay. How do I use laser pointer?
Sir, if you go below.
Okay. That pen light thing, huh?
Yes, sir. Yes, sir.
Okay.
So first one
Yes,
is
sir.
laser pointer.
Fine. So now, if you look at this population, along the y-axis, you have got light loss, and along the x-axis is size. Now, obviously, the size and lymphocytes have, the blue population of lymphocytes is hardly having any size as well as light loss. While the green population, which will be scattering more light, and because it takes up the staining dye, it will have more of absorbance and slight bit of refraction. and diffraction. Both these things are there. So you can see that along the y-axis, there is more light loss compared to lymphocyte. And here you have a population of cell which is same size as neutrophils along the y-axis, but they are having more light loss because of more scatter. Now there is a population here which is larger than these two cells, but having hardly any light loss are the monocytes. Now here also they use the principle of basolysis, like the previous cell counter, which like Xen from Sysmex as well as Mindray to identify the basophil. Here you have alinity, which uses both light scatter as well as fluorescence. So you can see here that the yellow population is the neutrophil, the blue population the lymphocyte. So you can see that the lymphocytes will have, size-wise along the y-axis, it's smaller in size, but scatter-wise it's smaller because x-axis scatter. So you can see that majority of the cell counter, the x-axis is usually scattered. So here you can see that cells which are larger than the lymphocytes but having more scatter are the neutrophils. And then you have cells which are larger than neutrophils along the y-axis, but having less scatter are the monocytes. Now it uses more polarized light to differentiate between neutrophils scatter as well as eosinophil scatter. So polarized light will be more scattered by the eosinophils, which is the green population here, and the eosinophils, and sorry, the neutrophils. And here you can see that they use fluorescence. And here the fluorescence is not because of RNA dye, but DNA dye. So obviously the, where is that? This is the fluorescence. So you can see that the neutrophils will have more fluorescence than the lymphocytes and the monocytes. And the advantage of this particular cell counter is that red cell data as well as the platelet data is purely optical. Now, interestingly, the cell counters, because of this differentiation and having a gating system where you can classify where the cells come, and they classify them as neutrophils, eosinophils, monocytes, lymphocytes, and basophils. If suppose some other scatter plot comes into other areas, it will start identifying them as not the regularly normal cells. Like for example, the population above the pink neutrophils will be called as immature granulocyte. And if it hits here, it will be called as neutrophilic blast. If it hits here, it will be called as monocytic blast. And of course, there will be blast for lymphocyte. So these are called suspect flagging. They basically tell you that this sample has got some abnormal cells. Maybe it's a good idea to look at the blood film. It indicates, and it will tell you what is the abnormal population that you may have. And sometimes it doesn't color it the right way because the abnormal population merges with the normal population. So the abnormal patterns are very good or best identified by cell counter, because you must realize that the cell counter analyzes all the cells 360 degrees. It looks at the cell all 360 degrees. It detects everything that the sample contains. It will of course give you a suspect flag if there's an abnormal cell like a blast. But we know that many systemic diseases processes bring about changes in white cells, red cells, and platelets. These changes are also reflected in this output, but they don't have a flag because they are within the gated population of these cells. So then we have to see what else can give additional information. So, we know that existing data like MCV is derived from the red cell histogram. RDW is derived from the red cell histogram. Basically, it tells you about the size of the red cell as well as the distribution of the red cell. Similarly, this data is also being collected by the cell counter for white cells. It will tell you what is the average size of neutrophil, how much is the distribution of neutrophils, what is the average size of lymphocyte, what's the distribution of lymphocyte, what is the average size. All these cell counters can give you data on the size, on the parameters. These are called as positional parameters, though derived from the histogram, but they may also reflect the true size of these cells. We have actually done the reference ranges on all these cell population data on white cells, and we have compared our data with data from Gangaram. I think Anil was involved with that. And then there was data from Hinduja, from Switzerland, from Miami in US, and we found that there's a good agreement between the reference ranges for neutrophils, lymphocytes, and monocytes among the population. There are cell population data for reticulocyte parameters also, because you can see that reticulocyte will be entirely based on how the reticulum is stained, whether it is stained by new methylene blue in Beckman Coulter or by fluorescent dye by rest of the cell counters. It will separate out the population purely based on the reticulin content, and then they will separate them as reticulocyte as well as non-reticulocyte. So they also give you the cell population data. Now, we all know the most common hematological condition in the world is iron deficiency anemia. It can be either frank anemia or it can be detected latent, or maybe the patient may be coming at the time when he's recovering and we don't know whether it's latent or recovering. There are a lot of biochemical parameters and they are criticized well because ferritin, acute phase reactant, serum iron. There are a lot of issues with that. We know that the gold standard for iron deficient erythropoiesis is free erythrocytic protoporphyrin, which is also called zinc protoporphyrin. Uh, it requires a proprietary equipment. It's not there in our country. So obviously, peripheral smear also helps because we have been taught that microcytic hypochromic anemia with anisocytosis is iron deficiency anemia. So we also know that iron deficiency anemia is characterized by low MCV and a high RDW with a low hemoglobin. But what I want to ask you is, looking at the picture, what is more obvious? Is it size or is it color? If you look at it, the difference in color is more obvious than difference in size. It is, it catches your eyes. So one thing that I learned was that the best indicator of iron deficiency and differentiating it even from beta thal major, where we may suspect some anisocytosis, is anisochromia, because anisochromia will not exist in a clonal disease. It will only happen when the clone keeps on getting affected by differential iron delivery. I'll show you an example here. 72-year-old gentleman, CRF on hemodialysis. His hemoglobin, he's got ischemic heart disease, so hemoglobin drops to 6.5. He gets orthopnea, and he gets admitted to hospital because he's short of breath. At the hospital, they find that his ferritin is 521. Of course, renal failure. They plan for a bone marrow. He panics and contacts us and says that, can you help me somehow? So I said, why don't you make a smear and send the smear, both fixed and unfixed, to us, and we stain it. So one of the things about anemia and chronic renal failure is one is erythropoietin component as well as the iron deficient erythropoiesis component. So now when I look at the smear, first thing is look reticulocyte. I can see in the smear, I can see 1, 2, 3 reticulocytes easily. So that means there is no deficiency in erythropoietin. He must be already on some dose of erythropoietin. I can see one reticulocyte here also. So I will say that there is no issues with reticulocytes. But what I can notice here is I can see anisochromia. Very clear anisochromia. That means there are some red cells which are very hypochromic, some are mildly hypochromic, and some are normochromic. So I want to find out whether the hypochromic red cells happen. Red cells have half-life of lifespan of 90 to 120 days. I want to know whether the hypochromic red cells happen 120 days back or 5 days back. Because if it happened 5 days back, we are talking about a bad story. If it's happened 120 days back, which means the better red cells happened 5 days back, we are talking about a good story. Now, obviously, that I can't predict from this. So what I look at the hypochromia of the reticulocytes. Now, if I look at the reticulocyte, I find one reticulocyte, because we know the reticulocyte's lifespan is only 1 to 2 days. I find one reticulocyte hypochromic and one reticulocyte normochromic. So there is anisochromia among the reticulocytes. One is hypochromia. That means this anisochromia is happening on a daily basis, which basically means iron is not getting to every erythroid cell equally as is expected in anemia of chronic disease or anemia of chronic renal failure. So the report is erythropoietin is adequate, but iron incorporation into the erythroids are deficient in uniformity. So he may probably require more iron. So they decided that they'll give him iron during the dialysis. Of course, they gave him 2 units of Paxil because his hemoglobin is 6.5 and he has got a history of ischemic heart disease. So red cell transfusion is indicated. He's symptomatic for oxygen carrying capacity, and therefore he got 2 Paxils. And 2 weeks later, his hemoglobin was 11.2 after treatment with iron. So you can look at some of these pictures and tell, for example, here everything. The reticulocytes are adequate, all are hypochromic, and therefore they'll require iron along with just iron alone. If I look at this picture with renal disease, there are hardly any reticulocytes in the picture. So that means he has also got hypochromia. So he will require erythropoietin, and if he's already on erythropoietin, his dose has to be increased. And then you have to realize that he has to get iron too. Now, how does the morphology? Of course, morphology was helpful, but every time morphology has very subjective. So you must realize that anisocytosis is reflected by RDW, hypochromia by this thing, but anisochromia is reflected by cell counters, by some of the cell counters, by percentage hypochromic red cell or hemoglobin distribution bit, but it will only give you the information of red cell 5 to 120 days from now. Then you must realize that what about hypochromic reticulocytes? There are certain cell counters which should tell you what is the hemoglobin content of the reticulocyte. And if the cell counters can tell you accurately the hemoglobin content of the reticulocyte, it becomes the earliest indicator of iron deficiency. Not iron deficiency, iron deficient erythropoiesis, the earliest, as early as zinc protoporphyrin or free erythrocytic protoporphyrin. Some of the hemoglobin content of the reticulocytes are calculated parameters like RET-HE and RHE from Sysmex and Mindray. Some are measured, which requires a proper MI algorithm because they use a slightly high angle scatter, because that scatter is because apparently of hemoglobin content. This is reflected as CHR or MCHR in ADVIA and Alinity. So you must realize that cell counter taught me a lot about iron deficiency anemia. It told me that anisochromia, which is the best diagnosis for iron deficient erythropoiesis, can be identified from cell counter by percentage hypo or HDW. CHR, which is the earliest indicator of iron deficient erythropoiesis, can tell you whether there is iron deficient erythropoiesis at all. And a treatment response is shown by the shift in HDW as good as MCH or probably better than MCH. And you must realize that cell counters also taught you some signs. I'll show you a scenario here. Post chemo, one of my colleagues here, a drop in hemoglobin is 5.4, obviously symptomatic. Low MCV, she's taking iron, definitely taking iron. So I get a call from her husband telling that we are coming to hospital. We have asked for 2 units of pack cells. Can you make sure that, because my colleague was HOD was not available, can you make sure that the good pack cells are available? Because I had the pack cell, the hospital number, I thought I'll look at a blood clip. There are hypochromic red cells with mild anisochromia. That means some red cells are good looking with a few well hemoglobinized red cells. And when I look at the reticulocytes or the polychromatophilic red cells, they are absolutely well hemoglobinized. So the response is responding well to iron. Okay, good. I'll just get some water. Responding well to iron. So then the only problem is when I look at the red cells, the well hemoglobinized red cells, and especially the reticulocytes, the well hemoglobinized reticulocyte, we know the reference range is 33 to 35. Now my inability in the morphology is that I can't say whether this 33. I know I can only say it's normal. I don't know whether it's 33 or 35. So I started. So we know that RET-HE, the reference range is 33 to 35. And then when I looked at the RET-HE value in this lady, because I know it's well hemoglobinized, it's not possible by morphology, even if it is a calculated parameter. So I called her husband and I said that, whatever red cell she's producing is phenomenal. It is taking up iron like crazy. Do you really want 2 pack cells? Because, we don't want, we know transfusion is harmful. We don't want any of our friends to be, close people we know to have transfusion. So they said, okay. But I said, if she's not that symptomatic, only weak, she can take 2 days bed rest. Anyway, we're taking blood after 2 days. We'll take it. We'll check the hemoglobin after that. And the hemoglobin after 2 days was 8.5. So that is the magic of this particular parameter. Now, some cell counters process reticulocytes by this particular process. What they do is for reticulocyte count, the red cells are here, biconcave shape. They actually put the stain, new methylene blue. It stains and precipitates on the cell. Then it spheres the red cell. And after that, it sends in a solution which clears the hemoglobin. And then what happens is when the red cells passes through, there'll be some scatter. So that will form the red cell parameter and volume based on size as well as scatter. But when the reticulocytes pass through, it will scatter more light and it will be having higher volume. So it will denote the reticulocytes that way. So the reticulocyte analysis based on this basically realizes that we actually are having a red cell which is more sphered. And we know that when the red cells become sphered, the sphered cell volume is going to be higher than the MCV. But in hereditary spherocytosis, we find that the spherocytes are critical to sphering. So when they get sphered, they get fragmented and they break up. So when you look at a normal red cell which is getting sphered, you can see the volume shifts quite high. But when a reticulocyte gets sphered, it starts lysing and breaking up into small particles, and their mean sphered cell volume becomes quite less. We actually thought we'll actually look at this data and see if the mean sphered cell volume is going to be lesser than MCV. It's going to be hereditary spherocytosis. If it's going to be more than MCV, it's going to be normal. So we found the difference of MSCV versus MCV, and when the difference is more than 20, it mostly indicates presence of spherocytes in the peripheral blood. That is, the MSCV is lesser than MCV by more than 20. Then we also found that reticulocytes in hereditary spherocytosis lose their membrane much ahead of autoimmune hemolytic anemia. So therefore, the mean reticulocyte volume will not be much higher than the rest of the red cell, which is the mean sphered cell volume. So when the difference is lesser than 25, we found that this particular equation can differentiate hereditary spherocytosis from other causes of spherocytes in the peripheral blood. Now, this was published, but now we have come out with a newer data in which if the MRV is less than MCV, it is nothing but hereditary spherocytosis. Now coming to fragmented red cells, we know that red cell histogram can depict fragments, but you must realize that fragments will interfere with platelet counts. Therefore, sometimes our optical data is much better, and you can see that optical data from Mindray and from Sysmex, when they do a reticulocyte count, they can identify smaller red cells, which they call as red cell fragments. But you have to be slightly careful because sometimes if you have microcytic hypochromic anemia, many of the small red cells will be identified as fragments. So this was a study that was done which worked a lot on fragmented red cell. So you must realize that mild hypochromic microcytic anemia results in overestimation of fragmented red cells. So true TMA or thrombotic microangiopathy showed high sensitivity and specificity for diagnosis of TMA when the FRC cutoff was 0.5. Overall high sensitivity and poor specificity because of the issue of microcytic hypochromic anemia being common in our country. The automated FRC percentage had a high negative predictive value. So one of the rules that you must use when you are using this parameter in cell counters, automated fragmented red cell, the FRC estimation by automated method tends to be progressively different from measurement by microscopy when schistocyte counts increase. FRC can be a useful tool to monitor thrombotic microangiopathy patients with gradually declining values, indicating therapeutic and clinical response. The role of peripheral blood examination remains the gold standard for accurate schistocyte estimation. Automated counting of FRC is merely a screening method and complementary to microscope. So you must realize this. Sometimes you can identify this fragmented red cells on your red cell histograms also. You don't need a 5-part cell counter. And it's significant when there's thrombocytopenia because sometimes the red cells are also being counted as platelets. So you must realize that schistocytes indicate presence of thrombotic microangiopathy in the absence of thrombocytopenia, cardiac valve, and B12 folate deficiency. But you must also realize that same histogram you can see when there are BITE cells or keratocytes, which are seen in oxidant hemolysis, unstable hemoglobinopathy, as well as hemoglobinopathies. So another case scenario here, 17-year-old male student of IIT Madras, also a staff kid. He had fever and diagnosed to have dengue. He was admitted by his dad in the ICU thinking that he will develop dengue hemorrhagic fever. His platelet count dropped to 75, then to many days, 4,000. So at 4,000, he asked, should we transfuse platelet? I said, the risk of intracranial bleed is when the platelet count is 1,000. He believed it because I never thought that you'll get a platelet count of 1,000 because if you run water through the machine, you'll get a platelet count of 3,000. And my luck or my bad luck, next day the platelet count was 1,000. So the issue is, our cell count is reliable when there is thrombocytopenia. We know that impedance platelet count is the most default platelet count in most of the cell counters. We must realize that it is done in the red cell chamber, and you must when the histogram is created based on the impedance, that is size, you can see the distribution is fairly more of the platelets are less than 10 femtoliters. It goes to 20. Then what it does is, because we know that there is physiological anisocytosis, there are some platelets which could be larger. It fits another curve and takes it beyond the measurement threshold to see whether it can accommodate those large platelets. And the area under the curve is the platelet count. So you must realize that unlike the red cell histogram or the red cell count, the platelet count is not directly taken from the cell counter impedance data. It is actually derived from the histogram. So what is measured in the cell counter is actually the histogram. So platelet count, I mean the histogram, platelet histogram is the impact of direct measure. It is not anything other than that. The platelet count, as well as other parameters like PDW, MPV, they're all derived from the histogram. Even platelet count is derived from the histogram. But look at the distribution. Most of the platelets in the physiological anisocytosis are less than 10 femtoliters. Here I've got a platelet count of 21,000. Look at the distribution. Most of the platelets are less than 10 femtoliters. If you look at the histogram, I will say that I will not see the slide, report the platelet count. Now here there are platelet count of 79,000. There are few large platelets. You can see that the population, though the population is mostly less than 10 femtoliters, there is more increase in population with 10 and 20, and it's accommodated to those large platelets which may go beyond 20 femtoliters. Even if you do a gold standard platelet count, it will still be 79,000. But when you get a histogram like this, where the events are not less than 10 femtoliters, more of the events are between 10 and 20 femtoliters, then you need to look at the peripheral smear because there is significant platelet anisocytosis. This platelet count was actually 250,000 when the cell counter gave it at 68,000. But the histogram told you to look at the. Now, when you get a histogram like this, we know that events are actually peaking at 20. It's not more between less than 10. It's definitely more between 10 and 20, but we don't know whether it's still more than that, more than 20 femtoliters. This is when the small red cells come and interfere with the platelet count, like fragmented red cells or iron deficiency anemia. So the manual platelet count was actually 30,000 in this when the cell counter gave it as almost 1 lakh. I have been looking at this boy's platelet count when it was 75,000, the one in the top picture. Then the one when it was 20,000. This was when it was, when it was 10,000, and this was when it was 4,000. But you can see that over a period of time, you can see that as his platelets start dropping, his normal size platelets start becoming larger. So young platelets are large because it's a stress hematopoiesis. There's peripheral platelet destruction. The marrow is trying to produce more platelets. It starts producing large platelets. So these I would call as large young platelets because they are looking more blue, and therefore I know that they are very young. So you can see this is also very blue, and they are large. So what are large platelets? Large platelets are basically those which go beyond physiological anisocytosis. But there's a definition for giant platelets, and giant platelets are those which are larger than red cells, like the picture you see below. This is a patient with Bernard-Soulier syndrome or constitutional disorders like May-Heglin anomaly. So what is the significance of large platelets in laboratory hematology? Because most of the cell counters are impedance, and we know that impedance platelet counts have a threshold. They may miss large platelets. But to a certain extent, when it is physiological anisocytosis, that is, there are no giant platelets, but it's only physiological anisocytosis, it still accommodates those large platelets. You can see that there are a few large platelets here, few more here, and much more here. But here, there are large platelets, but it's getting confused because these patients have got giant platelets. So can we say that MPV can indicate platelet size or platelet morphology? Let's look at it. This is MPV on normal people, and this is MPV on these people. You can see that MPV is becoming larger, higher as the large platelets increase, much higher when the large platelets are more. But when it comes to giant platelets, MPV fails to reflect the presence of platelets which are really large. So is there an alternative? You can have optical platelet count done by light scatter in NADVIA and LNT, and fluorescence-based platelet count based in Mindray and Sysmex. So when we got the fluorescent platelet count from Sysmex, we should actually validate it. So we selected normal donors as well as those donors who come from the eastern part of India who have got macrothrombocytopenia. And we also use the controls that we use regularly. So we found that when the platelets were large, like macrothrombocytopenia, the optical platelet count was higher than the impedance platelet. But the other interesting observation was that when the platelet distribution was normal, like normal donors or the QC material, the optical platelet count was always lesser than the impedance platelet count. We realized what is that? But then we realized when the distribution of platelets is normal, in the optical platelet count, which is based on fluorescence, some of the small platelets are cut out because of background noise, fluorescent background noise. When you have a data here, a patient who has got significant platelet anisocyte, you see that most of the data is most of the platelets are between 10 and 20 femtoliters. You can find out that. So I did a platelet count both in the cell counter, and I found that impedance was 40 and fluorescent was 46. They agreed, but I realized that because there is significant platelet anisocytosis, I must look at the smear and see. Look at that: 1, 2, 3, 4, 5, 6 platelets. So 6 platelets where the red cells are overlapping, multiply each platelet is equivalent to 15,000 platelet per oil immersion field. I get 90,000 platelets, which was actually the true platelet count. But because the impedance missed the large platelets and the fluorescent missed the small platelets, they give me a lower platelet count. In our place, when we have a normal histogram, whatever is the platelet count, release it. If the histogram indicates large platelets, do an optical platelet count and release it. But if there's significant platelet anisocytosis, correlate with smear and give them result. Now here also it's the same phenomena where the impedance and optical did not agree. But one thing that I noticed in this particular is that I've got a parameter called IPF. IPF is parameter which has been identified as probably predicting recovery of platelets, especially in peripheral platelet destruction. Though they are also looking for chemotherapy and bone marrow transplant patient, but predominantly for dengue patients. There's a paper from our place also. But this paper and most of the paper that talks about peripheral platelet destruction by viral infection, the recovery is 48 to 72 hours from now. So now you must realize that the father who is sitting on my head telling that I need a platelet for my son because the platelet count is 1,000. I told him I look at the peripheral blood and get back to him. I can't tell him that there's a paper here which tells you 48 to 72 hours. So then I realized that over a period of time, I realized from the time I got it that if you look at the scatter plot of the platelets, fluorescent platelet count, there's a direct correlation between fluorescence of the platelets and the size of the platelet, forward scatter. So if the size of the platelets is large, it will become immature platelets. If it is small, it will not be called immature platelet, even though we know that this platelet must have been very young. But it will not be called as immature platelets. Then many papers came which said that immature platelet count does not predict recovery of platelet count. So then we started thinking, okay, if it is indicating large platelets, we have got so many platelets with, macrothrombocytopenia. Let's evaluate them. And when we started evaluating them, we realized that all the patients who had macroplatelets or giant platelets, the platelet count was, the IPF was more than 60%. And sometimes those large platelets come in the WNR channel, which is the default WBC count. Some of these platelets get counted as the WBCs. So you can see that here. They get counted as lymphocytes. So immature platelet fraction is actually a misnomer because all our life we have not called platelets mature platelets. So there's no point in calling immature platelet. If you want to call something immature which does not function properly, you can probably call these platelets, which are not functionally important at the site of hemostasis, as immature platelets. They can sometimes be found in peripheral blood also. Now the importance of red cell platelet histogram is that you can identify large platelets and giant platelets on platelet histogram. So we compared a study where we looked at large platelet fraction versus the immature platelet fraction, and we found that the large platelet fraction correlated very well with the immature platelet fraction, which basically means there is no word called immature platelets. They were only large platelets. And large platelets are seen on platelet histogram. Coming back to this boy, I have been looking at his smear. And when I looked at his smear, don't think they're lymphocytes. They are actually platelets. These platelets, which are intensely bluish stained, I call them as stress platelets, which basically means the platelet megakaryocytes so highly reproducing that they are producing the stress platelets to come out, that the platelet recovery is imminent. So I told the dad that probably the platelet will recover in a short time. And of course, the next day the platelet count was 25,000. This confidence will come when you must realize always that hematology always happens in context of something else. And that's because we used to have this. I was monitoring this boy's white cell count also on daily basis, and I found that he had this particular pattern on his cell counter, which was totally different from normal. So, you can see that it had a different pattern. It looked as if, many reactive lymphocytes can go that way. For example, when you get virocytes like this, many reactive lymphocytes goes like that. But when they go along with the lymphocytes, they are linear along with the lymphocyte, whether they've got an angle or not, they go along linearly with the lymphocyte. But in dengue, this lymphocyte population will be going a little away from the lymphocyte flow. So you can see that that's because the dengue virus is monocytotropic. So these are monocytes which are merging with the lymphocyte population. And when the infection is very high, they hit the roof. So this particular pattern, which is a figure of 8, is very classical in dengue hemorrhagic fever. Dengue. And if you want an objective parameter for that, there is a parameter called high fluorescent lymphocyte count, which is a new parameter. Reference range, most of the people will not have more than 1. In patients with dengue, we can see that cases had much higher than controls. And when the infection became worse, the HFLC kept on going up and the infection receded. You can see the HFLC coming down. And interestingly, the HFLC was a mirror reflection of the platelet count. As the HFLC went up, the platelet count dropped. And as the HFLC dropped, the platelet count increased. So here you can have even a 24-hour prediction of platelet recovery if you are following up the HFLC count. So it's an objective parameter for a different mononuclear cell, a change in the cell, very early sensitive parameter to pick up dengue very, very early in the situation. So here we are actually talking about a morphology on the scattergram. That means a scattergram gives a particular type of morphology, which we can look at it objectively or subjectively and call it as dengue pattern. So this is a 43-year-old male in ICU. Patient has been recovering from a surgery. He had sepsis. And on day 17, the consultant felt that, and he recovered from that sepsis. On the day 17, he felt that the guy was looking quite unwell, toxic. He had a problem to straighten his left knee. So he thought that probably his guy has got a psoas abscess. So he called me and said, we have sent the samples in the morning. Can you look at the cell peripheral smear for toxic changes? Because the procalcitonin has come as normal. Maybe there are toxic neutrophils which I can probably think of starting antibiotics. Now, what are toxic neutrophils? We know that they look darker than regular neutrophils. They have more granules on them, and they have bluish color dolly bodies in them. So now, what are the utility of neutrophil CPD in identifying abnormal neutrophils or toxic neutrophils? Now, this is the cell count on this guy. His white cell count was 3,600, mostly neutrophils. And you can see that the neutrophil, nothing much more than looking at the fact that we're mostly neutrophils. And I compare it with a normal person, I hardly find any difference in the neutrophils with the normal person. So there was a study that was done many, many years back by Fernando Chavez when he was, because they thought that, toxic neutrophils, more granules, more scatter. So probably, it may be a best indicator of identifying sepsis. And when they did that study, they found only one thing. That is, the size of the neutrophil was higher than the reference range. You can see the reference range below. The size of the neutrophil is 138.05 to 151.31. While in these patients, they got the neutrophil size being high. So they said that neutrophil macrocytosis is a big indication of sepsis. But one thing they did not work too much on, they found that the neutrophil scatter, which they thought will be higher, was actually lower than the reference range. You can see that. Now, there is a philosophy for that. That's not philosophy, there's a physiology for that. You must realize that when the neutrophil comes from a myeloblast, it undergoes 4 changes. And these changes take place in 5 to 7 days. So you can see that the cell becomes, the blue color in the cytoplasm becomes grayish. From the promyelocyte to metamyelocyte, it becomes grayish. The granules start appearing in promyelocytes. It is there in myelocyte, but in metamyelocytes, they are not there because as the granules mature, they lose the sialic acid on their surface. And because sialic acid is gone, they will not take the basic dye. So the acidophilic granules are there, but they are no more acidophilic because they are no more acidic. So the granules are very much there, but they don't get stained. And the nucleus becomes smaller, band form and segmented. And the size of the myeloblast becomes half the size. So all these changes take 5 to 7 days. But when there is infection, this maturation can happen even in less than 1 day. Basically means only the nucleus becomes small, band form and segmented, while the granules do not lose their staining property. So the same amount of granules, but they take up more stain. So it's basically toxic change is a Romanowski mechanism. It has nothing to do with increase in more toxic granules. The blue part of the cytoplasm does not completely disappear, and they remain back in the cell as Dolly bodies, and the size of the cell does not become half. So toxic changes, Dolly bodies, and large neutrophils indicate neutrophils that have been produced in less than 1 day, which only happens in bacterial sepsis. So you can see this blue granules like Dolly bodies here. So you can see that this patient in another cell counter, you can see compared to normal, he had larger neutrophils because x-axis is size and y-axis is scatter. Not scatter, light loss. That means less scatter. So you can see these neutrophils are having less scatter. Now, when I look at these two data that I showed you earlier, this patient's neutrophil volume was 158 compared to a normal sample. So I called the consultant and I said that the patient has bacterial sepsis. Of course, I didn't see the peripheral smear. I told him that it's bacterial sepsis. So he said that procalcitonin was normal. I said, why don't you do one thing? Anyway, you have to start an antibiotic. You have to take a blood culture. You send another sample for procalcitonin. Second sample that he sent, the procalcitonin was in hundreds. So there is a study that has come in NEGM which says that sequential measurement of procalcitonin is a better marker of sepsis than a single measurement of procalcitonin. We have been seeing this regularly. Some of them remain as anecdotes because we don't get a time to do any studies. Some of them get studied, some of them get published, some of them just get written up and not submitted. So there was the study that we did in sepsis in adults, where we looked at patients who were in ICU with sepsis and those who were in ICU without sepsis, like hanging or, and of course, compare it with blood donors. You can see that the neutrophil volume was higher in sepsis patient compared to ICU controls, compared to blood donors. The neutrophil monocyte volume, this is one of the earliest paper which talked about monocyte volume being higher in controls than in blood donors. And the neutrophil scatter was lower in ICU sepsis patients compared to blood donors. So we found that the combined monocyte volume and neutrophil volume had a sensitivity of 82% for diagnosis of sepsis and specificity of 81%. In the neonatal study, we only looked at neutrophil data. We didn't look at the monocyte data. We found that the area under the curve for neutrophil volume at the time of admission or 2 days later was almost 0.82. And of course, low scatter was also almost close to 0.8. When we combine these two parameters, high neutrophil volume and low neutrophil scatter, along with the other parameters of sepsis like leukopenia and thrombocytopenia, the specificity of diagnosed sepsis almost came to 99.7%, and the sensitivity came to 90.8%. So this was published in a Nature publication, and it was quite a significant study. Now, the same patient, we ran the sample in Sysmex, and you can compare it with normal. This is normal. Actually, there's a patient has a left shift, but look at his neutrophil compared to the normal person. His neutrophil blue population, that is the sky blue population, is turquoise blue, is so high that it indicates that there is more fluorescence of this neutrophil population compared to the normal person. And that the reason for that is the Dolly bodies. You can see the blue Dolly bodies in this neutrophil. That's the reason why there was more fluorescence in the neutrophil compared to normal. We found that the high neutrophil fluorescence is also a good marker of sepsis with an area of under the curve almost 0.9. But what you must realize is that when you compare these two pictures, there's something missing. The patient with sepsis doesn't have eosinophils. So eosinopenia can also be an early marker of sepsis, provided you know that there is eosinopenia, because if you use the reference range from DAISY or any other books, compared to our reference range, which is 0.2 to 0.6, you will miss eosinopenia. So eosinopenia had an area under the curve of 0.74, which is much higher than procalcitonin in most of the studies in patients with sepsis, because you can see that the patient with sepsis had low eosinophil count compared to non-sepsis. So the other thing, of course, the study in Horiba is going on. So one thing you must realize, you have now in sepsis, you have larger neutrophils with the same amount of granules. So in larger neutrophils, when you have same amount of granules, the light will not scatter that much. So that was the reason for the low scatter. The interesting thing is, when you have larger neutrophils and low scatter, it will start merging with a monocyte population. So some of the neutrophils will be falsely called as monocytes. people are looking at parameters for diagnosis of sepsis because sepsis is a very important condition to diagnose. If you look at tissue culture, the cost is high, blood lactate cost is high, procalcitonin cost is high. Can we start looking at this cell counter data to see, can we diagnose sepsis at a available cost than having additional cost? This was a study that was done in Spain about 5-7 years back. They came out with a parameter which was called MDW, monocyte distribution width. It had a negative predictive value of 98% for diagnosis of sepsis, along with white cell count. So they created a new parameter that is monocyte distribution width. And then I realized that why should monocyte be widely varied? Then I realized that probably may not be two monocytes. So if you want to identify two monocytes, so everybody blames cell counters for giving higher monocyte count. So here you can see the green population is high in both the this one as well as this one. But if you can see the histogram, the monocyte peak comes here. So if this peak is there, that means your monocyte count is a true count compared to the next population where there is no peak here and there is no peak here. There are monocytes here. That's because the large neutrophils with low scatter gets counted as merges with the monocyte population, and many of the monocytes are actually not monocytes but neutrophils, and that causes the distribution of neutrophil to be wide. So rather than calling it an MDW, pseudomonocytosis can be a very good marker of sepsis. But one of the other interesting thing is when you find pseudoeosinophilia in sepsis, you can see the neutrophil volumes are going to be high. Monocyte is distributed, it's merging with the neutrophil population. We know it's sepsis. But when you have neutrophils which start getting higher scatter and being called eosinophils, which is called pseudoeosinophilia, that means the peripheral blood has got these neutrophils which have got the blue-green inclusions and vacuolization. This is a high predictor of mortality. Very high predictor of mortality. But even the cell counter can show you that. So there's a 35-year-old male with fever. White cell count is close to 11,000. There is a lymphocytosis, and you can see that lymphocytosis here. Now the same patient, 11,000 count. Again, there's a separate lymphocyte population, but this cell counter has got a patent on certain things. That means if the histogram shows a population outside the lymphocyte population, there are certain red cells which are not lysing and are being counted as lymphocytes. Some of them are not counted because they're red color. The lymphocyte distribution increases. The monocyte distribution increases because of the hemozoin pigment. It is a patent that has been awarded for a diagnosis of malaria. When 4 of them happen together, it is malaria. And when the population of non-lysed red cells are below the lymphocyte, it's vivax. And if it's closer to the y-axis, it is falciparum. Here you can see a case of vivax. You can see that many non-lysed red cells have been counted as lymphocytes. They are under the lymphocytes. While here you can see that they are closer to the y-axis. That's falciparum. This one is vivax. Now here you can see another cell counter. You can see that there's a population of abnormal neutrophils here. And if you twist it, you can see that this is a true neutrophil population. And these are the non-lysed red cells, which happens in vivax. So that is pseudoneutrophilia. While here you can see that there are many cells here which are being counted as eosinophils, but they're under the neutrophils. They are not having scatter as eosinophils, but because they're on the gate of lower fluorescence, they're being counted as eosinophils. But if you see the other angle, you can see those population here, which is nothing to do with eosinophils or neutrophils. That is pseudoeosinophilia, which can happen in falciparum. And of course, you have pseudo lymphocytosis in Horiba or Humicin. So when you have a count which is not predictable of what you are thinking, you must realize that don't blame the cell counter, because cell counter will only give you what you provided. So pseudo can actually be indicating a diagnosis. Like pseudobasophilia can indicate dengue in some cell counters. Pseudoeosinophilia and pseudoneutrophilia can indicate malaria in certain cell counters. Pseudolymphocytosis can indicate malaria in certain cell counters. And pseudomonocytosis can indicate sepsis in cell counters. So you must realize that, as I said about neutrophils have a different reference range in our country, which we have done on 3,000 blood donors from all over the country. You must realize that monocyte reference range also has to be identified. And I'm sure with a population which is having wide, tuberculosis being wide, the monocyte reference range may be different. Today I had a blood count done and my monocyte percentage was 10%. I took it with a I did, and not even with a pinch of salt. I just took it frankly. 4-year-old male. You look at the bigger histogram, his. Now his trail of lymphocyte or high fluorescent lymphocyte is straight, not like turned like this one in dengue. So when I see that, of course, I start thinking of viral infections because they are reactive lymphocyte. But at the same time, the neutrophils are also looking reactive. So this is an infection which causes both lymphocyte activation and neutrophil activation. The neutrophils are also having more fluorescence along the y-axis. So I call this a rocket tail pattern and increased neutrophil fluorescence. Other thing is, when we looked at the increased neutrophil fluorescence, we also looked at the forward scatter of the neutrophils compared to normal. And we found that these patients, the forward scatter of the neutrophil was lower. That means the neutrophil was highly susceptible to lysis. This is normal forward scatter of lymphocytes, neutrophils. Here you can see in the patients, it's all significantly reduced, giving a golf club pattern. This was a classical of scrub typhus. And 3 of them happened together. That is high fluorescent lymphocyte count, high neutrophil fluorescence, and low neutrophil forward scatter. It is highly indicative of scrub typhus. After this, they start patient on doxycycline. And after doxycycline, you can see that all these parameters significantly reduced. So scatter-bomb morphology can be early and reliable diagnosis of acute febrile illness, helps early institution of therapy and monitoring progress and response to therapy. Now, I will show you how an example, the last case, how we can use this data in clinical use. A 70-year-old retired and highly reputed professor of CMC undergoes resection of colon with anastomosis. Spikes fever on day 4. CRP is high. So day 4, day 5, when the fever, when there's a spike of fever, they think of anastomotic leak. They take them for re-exploration, and then of course repair it and bring it back. So anastomosis leak, the morbid, when they take them for repair, the morbidity is slightly on the higher side. And if you miss anastomotic leak, the mortality is quite good. Quite bad, very high. So they decide for take up for re-exploration again. Because it was a surgical ICU, the surgical ICU consultant said, call him for look for toxic neutrophil, because when there is an anastomotic leak, it's bacterial and they'll cause toxic neutrophil. And this professor's white cell count has been very high from day 1. You can see that white cell count is almost 30,000. But what am I seeing in the scatter plot? Neutrophils are looking very peaceful. But I am seeing high fluorescent lymphocyte count. But it's going along with the trail of lymphocytes, not dengue. Like neutrophil, if it's dengue, it will go a little lesser angle. So I'm sure that this is viral infection and not a bacterial infection. And there is no eosinopenia. As you can see, there are eosinophils there. Okay, I start running it on, so the high HFLC is 1.6%. So yes, it's a viral infection. And of course, the neutrophil fluorescence is not high. And so therefore, very clear, it is not bacterial. I run it on another cell counter, which I have. Again, what I look at neutrophil looks at a normal size. There are eosinophils. There is no eosinopenia. There is a merger between lymphocytes and monocyte, which happens in viral infection. In dengue, it almost forms a teardrop shape, which Dr. Anil had told me once. But here you can see it's only purely a lymphocyte monocyte merger, which basically means there are reactive lymphocytes, and this is a viral infection. So I called them. I said the cause of spike is viral. So the registrar says, "Are you sure?" The consultant says, "Are you sure?" The professor and head show asked, "What is sure?" There's a retired professor who came for the surgery because it's a senior person who was getting operated. He also asked. I said, "Yes, this is not bacterial, but viral." So there was no re-exploration done. Patient was recovered and discharged on day 11 from SICU in a very healthy condition. So yes, this can be very useful. So cell counter is the first screening test with results available within 1 minute of sampling. This screening test with its specifics no longer is a mere screening test, but provides specific diagnosis. My colleague Joy Maman calls this as machine morphology. I call cell counter hemocytometer. So I call this as hemocytomorphometer. Thank you very much. And I hand it over to my partner in crime in cytomorphometry and hemocytomorphometry, Dr. Anil Handu.
Thank you, sir. Thank you very much. I think that was an amazing presentation as usual. It couldn't have been done better by anybody. We all understand that, how the analyzer science has evolved in last about 1.5, 2 decades, and how you have actually single-handedly started the entire activity of making this analyzer science, kind of, people liking it so much that they'll get into it and, work into it. I think your cases were just too good. I genuinely do not think I really need to put in anything specific into this. And just one thing which I want to mention here is I think majority of the cell lines, whether we talk about platelets, whether we talk about RBCs, or whether we talk about the white cells and the parasites, of course, in all of these cases, we have certain parameters which are coming in from the analyzer, which potentially, are extremely either promising or something which can potentially be done and, put across for getting us the right information. So I'll really not get into it, and I'll probably ask Dr. Dongre to take it over with respect to the questions directly, rather than, though I have answered some of them online in the chat box itself.
Dr. Priya, would you like to take over?
Thank you, sir, Sukesh sir, and Anil sir. It was a very interesting talk, and Anil sir already answered most of the questions. And we have some questions. At what value do we consider thrombocytosis worrisome?
Thrombocytosis, I would say anything more than 5 lakhs is significant.
Okay, sir. And how do the hypohemoglobin and hyperhe and micro R and macro R can be used for diagnosis of iron deficiency?
Some of these parameters are coming, so micro R and macro R basically are from histograms. So it basically, but only cells counters which actually look at the hemoglobin content can come out with hypo He and hyper He. But when there are better parameters like CHR and HDW, HDW basically indicates what is your hyper He and hyper He, what I was talking about. So these are only going to widen the existing parameter. It's not going to add any extra knowledge. So if you have HDW and CHR or RET-HE, RHE or MCHR, that's good enough.
That's it, sir. Most of the questions were answered by Dr. Anil Landu.
I think there was one question which was regarding the mean spheroidal cell volume. Somebody wanted it to be explained further.
Yeah, yes, sir.
Okay.
Dr. Nair, if you could just take that.
Fine. So, in the VCS cell counter, the Beckman counter, the spherocyte count is done not by fluorescence. It's the only one which does by new methylene blue. So new methylene blue, you must realize, is a precipitant dye. So first they send the dye, and then after the dye stains, they sphere the red cell completely, sphere the red cell. And what happens is, and also dehemoglobinizes the red cell. So now you have a ghosted red cell, and you have reticulate. So now they use the volume and scatter to differentiate between, and of course conductivity also, but primarily volume and scatter. So obviously the red cells will have less scatter, while the reticulocytes which are having the reticulin will have more scatter, and because they are slightly larger in size, they'll have more size. So now the parameter, because it's also doing volume scatter, it can give you the mean volume of scatter, mean scatter as well as mean volume. So when it calculates the mean volume of the red cells, the whole red cell, that's reticulocytes and red cells put together, it's called mean sphered cell volume. So the volume, it's like the MCV, but mean sphered cell volume. It's an impedance data. While separately, it will give you a volume of reticulocyte. It's called mean reticulocyte volume. So MSCV is for all the reticulocytes, the red cell together, while MRV is only for the reticulocyte. So now what happens in this cell counter is when patients have spherocytes, they are not able to take in that much water, and the spherocytes rupture because there is problem with the volume inside the red cell. And when they rupture, obviously they record lower volume. So the mean sphered cell volume in patients with hereditary spherocytes or patients who have spherocytes is always lesser than the MCV, which was measured on normal red cells in the impedance channel or the red cell histogram.
Sir, in reactive thrombocytosis, platelet count can be more than 5 lakhs. Which cases require further investigation?
So I think, yes, you have to look at what would the cause of reactive thrombocytosis. Is there a recent history of fever, recent surgery? They can all cause reactive thrombosis. So we can give some time and repeat the platelet count to see whether the platelet counts are recovered. Because, patients who have got pertussis, platelet counts can be more than 10 lakhs. But there'll be a history of fever recently. If petechial hemorrhage is present in patients with thrombocytosis, yes, probably it could be. It could be. See, the other thing is when you have reactive not reactive thrombosis. When you have thrombocytosis, please look at the histogram. If the histogram indicates platelet anisocytosis, that may be an indication that this is not reactive thrombocytosis, maybe a clonal thrombocytosis. But the data has to come on that. But if you have reactive thrombocytosis with ecchymosis, then maybe it's a good idea to look for von Willebrand's factors. Not only just antigen, but also a functional assay, because there can be loss of high molecular multimers when there is thrombocytosis.
Sir, can thrombocytopenia and megaloblastic anemia present as bleeding manifestation?
Megaloblastic anemia
Yes, sir.
and thrombocytosis. Thrombocytosis, yes, definitely. You can have
Thrombocytopenia
thrombocytopenia in megaloblastic.
can present as bleeding manifestation.
Data is not much. There is not much of description of bleeding as such, but yes, you can have gum bleeds and all those things, but mostly primary hemostatic bleeding.
Okay, sir, that's it.
But the fact is that because there are a lot of fragmented red cells in megaloblastic anemia, you can mistake it for TTP also.
Yeah. So there was a question about Harris platelet syndrome, though I have answered it in the chat box itself, but I think, it will be pertinent here, to hear it from the horse's mouth.
Yeah. So, So long time back, I think in 1991, when Dr. Shashi, Abe, Bhave, they were all training here, they identified that patients who come from eastern part of India have lower platelet count, and therefore should we make platelet concentrates from them. And because 30% of our population of patients come from there and they are blood donors, so it was becoming difficult that should we really reject them for platelet concentrate, because a lot of they come for cardiothoracic surgery. So then we started accepting them, and we found that the platelet concentrate did match the quality control criteria for the FDA. But somebody else who came, we had a person called V.K. Harris who came. He thought that this can be published, so he started writing it up, and we actually wrote a paper long time back, much more long time back. It was called as asymptomatic constitutional macrothrombocytopenia. But then when I was in Australia, he had some data more. He had gone. I think by the time I came back, he was not there, and this data was published, and it was called Harris platelet syndrome. But it is still macrothrombocytopenia, but it's not a syndrome as such. It is still only large platelets. I don't know whether he's still working on it, but yeah, it's still the we still call it as constitutional asymptomatic macrothrombocytopenia.